Good day and welcome. My name is Katerina Tikhonova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of that treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are also helping you with the hotel. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника Лив, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники Лив желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Wadi Stan. It is that moment which makes you hold on to life, sometimes near a forest, sometimes in daily life. With its advanced diagnostic and treatment methods, that moment actually represents the future. There are some moments which makes you look to the future confidently. Those moments are the future. Live Hospital, the future of healthcare, opened in Wadi, Istanbul.
В Вади, Истанбул, открылась больница будущего EBUS Hospital, отличающаяся опытом в уходе за пациентами и гостеприимным подходом к своим пациентам. Порой расположение на краю леса, порой в жизни наступит момент, когда продвинутые методы диагностики и лечения помогут вам выжить. Этот момент обязательно настанет. Есть моменты, когда вы начинаете смотреть в будущее с уверенностью. Так вот это именно этот момент будущего. В Вади, Истанбул, открылась больница будущего EBUS Hospital.
Merhaba, ben Profesör Doktor Levhi Akın. 2014 yılından beri EBUS Hospital Ulus'tayım. Genel cerrahi ve cerrahi onkoloji uzmanıyım. Aynı zamanda Tıbbi Yürütme Kurulu üyesi olarak idari bir görev de yapmaktayım. Şimdi beraberce EBUS Hospital Ulus'un içine gireceğiz ve sizler için hastanenin ne kadar güvenli olduğunu gösterebilmek için birlikte bir hastane turu yapacağız. Güvenlik ünitemizi geçtikten sonra tarama bankomuza geliyoruz. Burada uzaktan ateş ölçümümüz yapılıyor. Daha sonra yakın özgeçmişimizle ilgili bir takım sorular sorularak kayda geçiriliyor. Taramamız tamamlandıktan sonra taramayı başarıyla tamamladığımıza dair yakamıza bir etiket iliştirilecek. Hastanede bulunduğumuz süre içinde bu etiketi sürekli yakamızda taşıyoruz. Buyurun. Evet, içeri girdikten sonra önce danışmaya giriyoruz. Burada görmüş olduğunuz gibi sosyal mesafe kuralları açısından gerekli önlemlerimiz alınmış durumda. Girişten itibaren sarı çizgilerimizi devam ettiğiniz zaman onkoloji hastalarımız için özel olarak tahsis edilmiş olan asansörümüze ulaşıyorsunuz. Öncelikle şunu ifade etmek istiyorum. Bizler için en önemli olan şey sizlerin ve hastane çalışanlarımızın güvenliği. Biz sizlerin sağlığı ve tedavisi için buradayız ve hizmete hazırız. Misafirlerimize açık alanlarda ve bekleme bölümlerinde bir takım tedbirler aldık. Gördüğünüz gibi sosyal mesafe kurallarına uyabilmek için işaret gördüğünüz alanlara oturulmuyor. Diğer alanlara oturuluyor. Oturulan alanlar her yarım saatte bir temizlik personeli tarafından siliniyor ve temizleniyor. Hastanemizde gerek hastalar, gerek ziyaretçiler, gerekse de refakatçilerle birlikte tüm hastane çalışanları için maske takılması zorunludur. Şimdi bir hasta muayene odasını birlikte göreceğiz. Zaten hep temiz olan yerler. Fakat bu dönemde biz bu işe daha çok konsantre olduk. Her hastadan sonra örtülerimiz zaten değişiyordu, gene değişiyor ama yüzeyler tekrar siliniyor. Sehpalar, her hastadan sonra sandalye kolları, kapı kolları, ışık düğmeleri hepsi temizleniyor. Ayrıca Türkiye'nin dört bir yanındaki hastalarımıza video klinik olarak da hizmet verebiliyoruz. Bilgisayar üzerinden kamera aracılığıyla sizler bizi görebiliyorsunuz, bizler sizi görebiliyoruz. Burada bilgisayardaki bütün sonuçlarınıza ulaşabiliyoruz. Tıpkı yüz yüze görüşüyormuş gibi sonuçlarınızı değerlendirebiliyoruz. Poliklinik hizmetlerimiz güvenli, acil servis hizmetlerimiz güvenli, tetkikleriniz güvenli, ameliyatlar güvenli. Ameliyathane güvenliği için de gerekli tedbirlerimizi aldık. Bu konuda şimdi ameliyathane sorumlumuz Profesör Doktor Didem Dal Hoca ile görüşeceğiz. Buyurun. Profesör Doktor Didem Dal'la birlikteyiz. Sayın hocam, bu süreçte ameliyatlarla ilgili ne gibi tedbirler aldık?
Bu hassas dönemde kesinlikle sağlığınızı ihmal etmeyin. Sağlığınız için gereken tetkikler, gerek bir ameliyat, herhangi bir işlem gerekiyorsa güvenle, doktorlarınıza güvenerek, hastanelerinize güvenerek gelebilirsiniz. Çünkü onlar sizler için, sizlerin güvenliği için tüm tedbirleri alıyorlar. Aynen kendi sağlıkları ve güvenlikleri gibi sizlere de her tür hizmeti sunmaya hazırlar. Bizler de bunları yapmaya çalışıyoruz.
Benimle bu hastane turuna katıldığınız için teşekkür ederim. Live Hospital Ulus'u sizler ve hastane personelimiz için mümkün olan en güvenli hale getirdiğimizi umuyoruz. Sizler için buradayız ve hizmete hazırız. Tedavilerinize devam etmek istiyoruz. Unutmayınız, güvenliyiz ve sizi de güvenli tutmak için buradayız.
Good morning. Welcome, everybody. Can you hear me? Okay. So welcome our EBUS course. You are all welcome. In this activity, we have to be designed to educate the pulmonologists and thoracic surgeons, of course, as well as other healthcare professionals in the teaching of endobronchial ultrasound. This course is designed to offer a comprehensive training in EBUS, and it covers the theoretical knowledge that is required for EBUS. So today's program is started with me. I will explain the EBUS technique and performance. And okay. Okay, endobronchial ultrasonography is a new diagnostic modality. There is an ultrasonic probe at the tip of the bronchoscope, so we can see some sonographic images of the peribronchial tissue. EBUS visualizes structures within and adjacent to the airway. The main indication is the evaluation of mediastinal lymphadenopathy, benign or malignant. If you compare EBUS with mediastinoscopy or conventional TBNA, we can say that mediastinoscopy yields good results, but it's highly invasive, as you know. In conventional TBNA, the procedure is less invasive, but the yield is variable. Therefore, EBUS has emerged as a technique that combined the high yield of mediastinoscopy with the minimal invasiveness of TBNA. It's a safe procedure. You can access with EBUS into a very wide range of mediastinal lymph nodes, like 2 lymph nodes, 4, 7, 10, and 11, both right and left nodes. However, stations 5, 6, and 8 lymph nodes cannot be visualized by EBUS. You have to use EBUS, endoscopic ultrasonography, in order to reach the station 5, 6, or 8. If you cannot reach the diagnosis, a negative sample, you have to move on with alternative modality in order to take the tissue, like surgical biopsy or mediastinoscopy. Why EBUS may fail to identify, especially N0 or N1 disease? If the tumor is left-sided, you cannot reach number 5, number 6 stations, so it may fail. If the small node the lymph node diameter is small, then you cannot reach that small diameter nodes, it may fail. If in one station area, if there are some multiple small nodules, very small nodules, the needle cannot reach the exact lymph node tissue, so it may fail. According to this review, in this review, 14 studies are examined, and they included more than 1,000 patients. And the review emphasized that EBUS TBNA is a safe procedure with a high yield and sensitivity for diagnosing, especially central located lung tumors. In this study, the diagnostic yield was about 91%. 5% was inconclusive, and 5.5% was for false negatives. It is consistent with the literature. According to this review, published very recently, mediastinal lymphadenopathy is a common problem, and minimally invasive endosonography techniques must be used because they are safe and diagnostic yield is good. Therefore, these modalities, endosonographic modalities, either EBUS or EBUS, are the preferred first-line investigations in most of the patients. And also in this review, they reported a diagram which I like it very much because it summarizes very briefly if the patient has mediastinal lymphadenopathy on thoracic, her or his thoracic CT scan, then we have to evaluate the characteristics of the lymph nodes. If the lymph nodes are homogeneous and the suspicious diagnosis is sarcoidosis, then we have to do biopsy. If it's significantly enlarged, you can do conventional tDNA, but it's not, if it's small, then you need EBUS. And the lymph nodes, if the lymph nodes are heterogeneous and the tuberculosis is suspicious diagnosis, then again you need EBUS biopsy. If the node is enlarged, and you can suspicious about bronchogenic carcinoma, of course, then if the bronchogenic carcinoma is the pre-diagnostic disease, then you have to use EBUS tDNA. But adding rows, which is rapid on-site examination evaluation, increases the percentage of the diagnostic yield. So along with EBUS, you can use rows in bronchogenic carcinoma patients. And also, if there is an anterior mediastinal mass and you are suspicious about lymphoma, then again EBUS tDNA, you have to use EBUS. In extrathoracic malignancy with mediastinal lymph nodes, then you have to use EBUS tDNA. Again, if the nodes are large enough, you can use conventional tDNA, but using EBUS tDNA is safer than the conventional ones. So this flow chart shows us that in mediastinal lymphadenopathy, you have to start with EBUS. There are two types of endobronchial ultrasound, which is the first one is radial probe, the other one is convex probe. Radial probe is commonly used for the evaluation of pulmonary nodules. In this bronchoscope, the ultrasound waves shows the image of 360-degree grayscale. It allows real-time imaging, but unfortunately, it doesn't allow real-time guidance. The convex probe EBUS, in convex probe, a convex ultrasound is attached to the tip of the flexible bronchoscope, and the scale image is parallel to the insertion of the bronchoscope, as you see here. This is a radial probe. This is convex probe bronchoscope. So as you see here, the images are a little bit different from each other. Most probably, convex probe is frequently used all around the world. Here in our hospital, also we prefer convex probe EBUS because it's a safe procedure, and we can have the advantage of Doppler imaging, which is used to delineate vascular structures. If you have facility for rapid on-site evaluation, then it means that patients typically receive a preliminary diagnosis after the procedure immediately. So there are some differences between radial probe and convex probe EBUSs. As I said before, the angle of view in radial probe is 360, in convex probe 90 degrees. So in convex probe, penetration is more than 5 centimeters. On the other hand, in radial probe, it is less than 5 centimeters. Resolution is comparatively worse in radial probe than convex probe. If you want very well visualization of the airway wall, then in radial probe, you should use balloon inflation. But in convex probe, it's not a must. And also in convex probe, you have advantage of Doppler ultrasonography, and also real-time sampling is available in convex probe bronchoscopy. The success of EBUS is predicated by some factors, which is patient selection. It's very important. Available equipment and the management of specimens. According to me, the most important one is the management of specimens. Acquisition, processing, and interpretation is very important. So you have to very well educated pathologist with your team, so you can achieve diagnosis correctly. The procedure can be performed under moderate sedation or with general anesthesia. It depends on bronchoscopist and the center's availability. So there are two commonly used airway devices, which is endotracheal tube is for general anesthesia, and the laryngeal mask airway is for moderate sedation, or again, if you want to reach the second lymph nodes, number 2 stations, then you have to use laryngeal mask in spite of general anesthesia. So in our hospital, we prefer general anesthesia, and we are doing EBUS procedure in the operating room. And it really increases the patient's comfort. So I'd like to move on to the procedural steps for EBUS. First, we start with equipment. The convex probe EBUS bronchoscope is used commonly, and it's connected to an ultrasound processor, because with this processor, we can measure the lesion, label the lesion, and also it helps us to identify vascular structures. There are many aspiration needles in the market, like here you see, but the most commonly used ones are Olympus and Coop EBUS needles. For optimization of the ultrasound imaging, a latex balloon can be attached to the tip of the bronchoscope, and you have to fill it with saline according to the location of the bronchoscope. The insertion is very important because you have to be very careful when you insert EBUS bronchoscope, because you cannot see the tip of the scope. The quality of image is lower than conventional bronchoscope, and it provides an oblique angle view. So you have to be very careful when you pass the vocal cords. Otherwise, you can harm the vocal cords. You can harm the mucosa of the bronchus. Here you can see the angle view EBUS region. So it is, you are not comfortable as comfortable as a conventional bronchoscopy. So if you don't use an endotracheal tube, then the scope must be passed throughout the vocal cords because you have to visualize the anterior angle of the glottis. Otherwise, you can harm, as I said before, you can harm the vocal cords. So when you pass through the vocal cords, your thumb must be down in order to flex bronchoscope slightly anteriorly. After insertion of the bronchoscope, then we find the lymph node by ultrasound. So if you are in mid to distal trachea, you can inflate the balloon, and you can see the imaging very qualified. And visualization of areas such as hilar lobes or interlobar lymph nodes, you may need a small amount of saline, like 0.3 milliliter saline, in order to inflate the balloon. But if you take more proximal area for the scope, then you need, in the large areas, you need a little more than 0.5 milliliter of saline for best visualization, for best contact with the bronchial wall. And due to the angulation of the airway, station 4L is a difficult area for the EBUS scope to make a contact with the bronchial wall. Then, if the patient has a bronchial carcinoma, so you have to perform staging. Therefore, in order to avoid contamination and upstaging, the starting of the station should be the contralateral hilum or mediastinum. For example, if you evaluate a right lung lesion, then the staging should start at station 11L and typically conclude with station 11R. So first start with N3, then move on to N2, and then conclude it with N1, please, in order to prevent upstaging. Okay, sampling technique is a complicated one, really complicated one. So first, the aspiration needle, the EBUS needle, is inserted through the instrument channel. But while doing this, you have to be in neutral position. Otherwise, you can damage the channel of the bronchoscope. And when you lock bronchoscope adapter to the bronchoscope, then, excuse me, the sheet adjuster knob is released and the adjuster is pushed down until the sheet is visible, like here. You see the sheet first. Then tighten the knob, please. And after locating and positioning the lymph nodes by ultrasound, then the stopper here, you can adjust stopper according to the diameter of the lymph nodes, according to, for example, 2 centimeter, 3 centimeter, 1 centimeter, etc. Then the needle adjuster is unlocked by pushing the lever, and the needle slider is pushed down until the needle is advanced into the target. You will observe the needle coming from the right upper corner of the ultrasound image and will advance it obliquely from right to the left. When the needle is in the target, in the lymph node, then you move the stylet up and down at least once in order to eliminate the bronchial epithelium that passed into the needle. And then pull back the stylet out completely. And the suction system can be attached here. The suction system can be attached. And the needle is moved up and down at least 5 to 15 times into the target, into the lymph node, from its upper to lower edge. Not in minimal movement, but a little bit large movement from upper edge to the lower edge. You have to move up and down periodically. Then the suction must be turned off and the needle adjuster is pushed back into the position and locked by pulling the lever. And the bronchoscope must be again in neutral position and the aspiration needle can be withdrawn right now. So I'd like to repeat it with pictures again so you can understand and you can imagine in your mind. First, we put the EBUS needle into the bronchoscope and we have to be sure that the scope is in neutral position in order to prevent bronchoscope damage. Then also the sheet adjuster knob must be faced outward for the real and good insertion of the needle. So you secure the needle to the bronchoscope by locking it. Then first release the sheet adjuster knob and adjust the sheet so you can see that in endoscopic view. Then tighten the knob and locate the target area, locate the lymph node on ultrasound image. If you find the lymph nodes, then release the needle adjuster here after adjusting stopper here, according to the diameter of the lymph node. For example, here you see 2 centimeters adjusted. Then advance the needle into the target area. Sometimes there are some artifacts in lymph node. If artifacts is visible, then you have to adjust EBUS scope tip until the artifact disappears. Push a little bit EBUS scope so you can see the real image and you can visualize needle entering target lymph node. Before removing the stylet, don't forget to push at least once back and forth in order to get rid of epithelium, bronchial epithelium. in the middle. Then attach the prepared syringe and apply suction by turning the stopcock, but it's not a must. According to some studies, the suction was not statistically significant compared to no suction. So you can do it without any suction. Therefore, it's not a must. But in our hospital, we use suction in order to get a better material from the lymph nodes. So it depends on the bronchoscopist's choice and also the facilities of the hospital. Then move the needle slider into the target several times, at least 5 to 15 times. Then the procedure is completed. Turn the stopcock to release the suction. Remove the syringe out. Pull the needle slider upwards until it clicks. This retracts the needle into the sheath, so you feel safe when you do this. And pull the needle adjuster upwards into the position. And again, don't forget to place the scope in a neutral position. Unlock the needle and remove it. Then extend. You have to connect needle into an air-filled syringe. Then you can have a specimen on the slide, very gentle. After this procedure, you dispense the remaining specimen into the cell block container, which is very important. Then you can repeat this step as needed, as much as needed. So endoscopic locations of lymph nodes accessible by convex probe, I'd like to give some brief information about it, some trick points. For example, for lymph nodes number 2, the left lateral border of the trachea is very important because it separates the left from the right stations. On the left side, you can reach number 2L, but the lymph nodes immediately anterior to the trachea are the right paratracheal nodes, not in clockwise rotation, just in the middle of the anterior trachea, you can reach right paratracheal lymph node, who are lymph nodes. 4L is in 9 o'clock position in the distal trachea. The upper border is the transverse plane of aortic arc, and the lower border is the superior margin of left pulmonary artery. 4R is between 12 and 3 o'clock in the distal trachea, just above the main crania, and the inferior border of the 4R is inferior margin of the asclepius vein. The 7th lymph node can be located on the right or left main stem bronchus. You can reach them from medial wall of each bronchi. In here, in our hospital, we prefer right main stem bronchus, so it's much easier than the left main stem bronchus. Of course, it depends on the bronchoscopist's experience. 10L is typically found in left main stem bronchus around the 10 o'clock position, and the 10R is located in right main stem bronchus under the lower rim of the azygos vein. In order to reach 11L, you have to advance the EBUS scope to the opening of left lower lobe, and just place the transducer on the lower surface of the interlobar carina and typically rotating the scope slightly to the left. For 11Rs, they are located between upper lobe bronchus and the bronchus intermedius on the right lateral wall. So you have to rotate the scope slightly to the right. Okay, sometimes there can be some troubles. For example, you can face with hyperechoic parallel lines in ultrasound image. So it means that the ultrasound probe, or if you use balloon, it doesn't have enough contact with the airway wall. So you have to reposition the EBUS probe, or you have to add a little saline adding to balloon inflation. So these procedures can solve the problem. In case of latex allergy, if your patient is allergic to latex, then the procedure must be performed without the balloon. When your camera has a clot, we cannot see anything. So you have to get rid of that float. If you're using a balloon, then deflate it. Or if you don't use the scope, you advance the scope into the distal area, and the scope must be pulled up, rubbing the walls, and together with suctioning, then it helps to clean the camera. There are some clinical applications before the EBUS procedure. For example, determination of the depth of tumor invasion of tracheal or bronchial wall, because the diameter is very important. The use of needle and also the characteristic of needle you can arrange according to this result. Analysis of structure of the bronchial wall, such as tracheobronchomalacia, is important. And identification of the location of peripheral lung lesion during bronchoscopic examination is very important. And qualitative analysis of peripheral lung lesions, there are some new methods I will talk about in a few minutes. Then we can differentiate benign or malignant lesions between each of them. The indications, the main indication is the lung cancer staging, mediastinal and hilar staging of lung cancer. If there is a diagnosis of cancer suspicion, but there is no endobronchial lesion, you have to use a lymph node biopsy by EBUS. Also, recurrence or restaging of non-small cell lung cancer after chemotherapy or radiotherapy is a definite indication for the EBUS. There are some other indications like mediastinal lymphadenopathy, suspected sarcoidosis, tuberculosis, mediastinal lymphoma, thymoma, and some mediastinal cysts. There are some contraindications like unstable angina, refractory hypoxia, hemodynamic instability, bleeding diaphysis, and coagulopathy. Also, the main contraindication, according to me, is the inadequate expertise and inadequate facilities and equipment to handle complications. This is very important. Okay, I'd like to mention about the imaging from the positions of the bronchoscope. So, for example, if you are in upper trachea, what are you seeing from the ultrasound view? So, if you are in upper trachea on clockwise rotation, you will see brachiocephalic veins. The lower border of the left brachiocephalic veins forms the upper boundary of station 2R, so be careful. On anticlockwise rotation, the upper margin of the arcus aorta is seen. From the right side of trachea, brachiocephalic trunk crosses. And for the left wall of trachea, the left common carotid artery runs. The transverse plane through the superior border of aortic arc makes lower border of the station 2L on the left, and brachiocephalic vein forms lower border of 2R lymph nodes on the right side. If you are in lower trachea, clockwise rotation just above carina shows superior vena cava. So if you continue to make clockwise rotation a little bit further, then the azygos vein can be seen joining the superior vena cava. The interior border of station 4R is formed by the inferior margin of the azygos vein. So you have to be very careful. Therefore, using Doppler ultrasonography is very important in order to locate lymph node and the attachments between lymph nodes and some vascular structures. In anticlockwise rotation shows arc of aorta in the left anterolateral wall, and the superior margin forms the boundary between the station 4L and 2L lymph node stations. If you are in right main bronchus, then subcarinal space, you can visualize the subcarinal space, right pulmonary artery, right pulmonary vein, superior vena cava, and ascending aorta. If you turn the scope anticlockwise, then you can reach the number 7 lymph nodes in the subcarinal area. The station 10R lymph nodes are seen close to the right main bronchus on the clockwise rotation. If you are in intermediate bronchus, then you can visualize some cardiac structures. If you push down the endoscopic visualization, then you can visualize 11 lymph nodes station. it is very close to intermediate bronchus in clockwise rotation. If you are in the left main bronchus and the upper part of the left main bronchus, the proximal part of left main bronchus, you see a left pulmonary artery. On anticlockwise rotation, you see descending aorta, esophagus, and vertebral column. Station 10L are seen near the left main bronchus on anticlockwise rotation. If you do a clockwise rotation, you can reach again subcarinal node 7, number 7 lymph nodes. The imaging from lower part of left main bronchus shows us secondary carina lymph nodes of station 11F. So as a summary of the stations, like in upper trachea, you will see brachiocephalic trunk, left common carotid artery, left subclavian artery, right and left brachiocephalic veins. You can reach lymph nodes number 2R and 2L, and vertebral landmark is T3. In lower trachea, you will reach arc of aorta, superior vena cava, azygos vein, and you will see the lymph nodes number 4R and right and left, and the vertebral landmark is T4. In right main stem bronchus, you will visualize right pulmonary artery and superior vena cava. You can reach from this station. You can reach from this station to lymph node 7 and 10R. The vertebral landmark is T5, the upper border of T5. In the from right intermediate bronchus, you visualize right pulmonary artery and right pulmonary vein, and also the lymph nodes. You will see 7 and 11R. The vertebral landmark is T5. In left bronchus upper part, you will see left pulmonary artery and descending aorta. You can reach 7 and 10L lymph nodes. Vertebral landmark is T6. In left lower bronchus, you will reach the left pulmonary artery and left pulmonary vein, and you also see the lymph nodes number 7 and 11L, and the vertebral landmark is T6. But there are many novel technologies in order to increase the diagnostic yield of EBUS. So especially for cancer, lung cancer patients, the elastographic techniques have recently become available in order to increase the quality of the tissue sample. It's an ultrasonographic new method for generating objective strain images of tissue compressibility. EBUS elastography has made it possible to detect and colorize the hardness of lymph nodes. For example, hard tissues are shown in blue, and hard tissues represents malignant lymph nodes, while intermediate tissues are shown in green, which represents inflammatory lymph nodes, and the soft tissues are shown in yellow or red. Here I want to show you some examples. For example, here you see normal lymph nodes between the arrows, green lymph nodes, some parts are red. Here you see pure green lymph nodes and homogeneously green lymph nodes. This is inflammatory mediastinal lymphadenopathy, so it's a benign lymph node. Here you see homogeneously blue lymph node tissue. This is malignant infiltration of lung cancer. This is a malignant lymph node metastasis. Also, you see here circumscribed blue appearance, which is metastatic infiltration. So you have to put your needle into this area. If you go this way, this lymph node is negative, gives negative results. So it's a false negative. You have to put your needle into this blue area, so it will increase the correct diagnosis rate. This is a meta-analysis, and here it is suggested that EBUS elastography is a reliable technique for intrathoracic lymph nodes, and also sensitivity and specificity is reported as like 90%, 93% for sensitivity, and 85% for specificity. But the authors emphasize that a biopsy specimen cannot be replaced by elastography. So tissue is the issue. Therefore, you have to take a sample, and the biopsy specimen is the gold standard. As a summary, I'd like to mention about chest guideline and expert panel report. Okay, first, in patients undergoing EBUS cDNA, it's suggested that either moderate or deep sedation is an acceptable approach. So it depends on bronchoscopist's choice, and it depends on the facilities of the hospital. Here in our hospital, we prefer, as I said before, general anesthesia, and also we are doing EBUS procedure in the operating room. 2, in patients undergoing EBUS cDNA, it's suggested that tissue sampling may be performed either with or without suction. So suction is not a must. You can do it with suction or without suction. It's up to you. We prefer doing a biopsy with suction in our hospital. The other one, in patients undergoing EBUS cDNA, it's recommended that the use of either 21 or 22 gauge needle is an acceptable option. In our hospital, we use 21 commonly, but also we can use 22 gauge needles. In patients undergoing EBUS cDNA for the diagnosis or staging of suspected or non-small cell lung cancer, it's recommended that additional samples beyond those needed to establish diagnosis should be obtained for molecular analysis. So it's the aim is not just diagnosis, so you have to get additional samples in order to help the pathologist to be help them to do molecular analysis, because as you know, for lung cancer, the targeted therapy is very important in this decade. Okay, there are some complications, but the rate of the complications are very rare, and therefore the most commonly seen is pneumomediastinum, pneumothorax, hemomediastinum, mediastinitis, and bacteremia. There are some bleeding complications, but very rare and very mild. Even you puncture the vessel inadvertently, so it's not so important. Okay, I'd like to finish my talk with the NCCN guideline, the recent version in non-small cell lung cancer. According to this guideline, the least invasive biopsy with the highest yield is preferred as the first diagnostic study. These are EBUS, EBUS, navigational bronchoscopy, then diastoscopy. So start with EBUS. And also addition of EBUS and endoscopic ultrasound like biopsy gives us chance to reach to station 5, 8, and 9 lymph nodes if these are clinically suspicious. Okay, right now I'd like to thank all of you, and I'd like to proceed. Before proceeding the other speaker, I'd like to take your questions or comments on this procedure. Are there any comment or question you want to ask? I'd like to wait a little bit, maybe there will be some questions or comments on this. Okay, I think everything is understood clearly. So we can move on the other speaker. My colleague, Professor Dr. Çağatay Tezer, he is a thoracic surgeon, and he will talk about mediastinal lymph nodes anatomy.
Hi. Here at Live Hospital, we care life. Welcome to the future of healthcare.
Good day and welcome. My name is Katerina Tikhanova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and
Bu mu?
Evet. Sonu hangisi? Şu.
Bu.
Evet. Tamam. Başlayalım. Başlayalım.
Okay. Hi. I wish thank to the society, the committee. It's a great pleasure for me to be invited and a warm welcome to you all for this our International Medical Academy of Science EBUS Forum. Now, I wish to you all great information about the mediastinal anatomy because of if you want to do any type of mediastinal operation, including EBUS, we should all know the exact locations of the boundaries of the anatomy of the mediastinum in terms of both the mediastinal tumors or the mediastinal lymph nodes as well. So here's our schematic view of the mediastinum. We have got four components of the mediastinum. Here's the superior part and the anterior part, the medial mediastinum and the posterior mediastinum as well. The adjacent colorosite form shows us the parts of the mediastinum as well. The tiniest part is the anterior mediastinum. The mediastinum is the region in the chest between the pleural cavities that contains the heart and other thoracic viscera except the lungs. So the boundaries are in the lateral part is parietal pleura, the anterior part is sternum, the vertebral column lies the posterior part of the mediastinum, and it begins from the thoracic inlet down to the diaphragm. Here's the plain chest X-ray, shows the boundaries on the screen. The superior mediastinum boundaries are, as I told you before, the mandibular sterni here in the anterior part, the T1 to T4 vertebral bodies, mediastinal pleura, which contains is formed from the inside one, and the joining sternal angle to the lower border T lobe and imaginary line shows us the bottom line of the anterior mediastinal space. The superior mediastinum contains the veins as well. So the most of those veins are superior vena cava, the brachiocephalic veins, supreme intercostal veins, and the superior intercostal veins. And the arteries are the aorta, the arc of aorta, the brachiocephalic artery, the common carotid artery, and the left subclavian artery. What might be the pathology of this anterior mediastinum? So it might be a tumors which could be represented in the childhood period, and the sternopericardial ligaments, the internal thoracic artery and branch, and lymphatics and lymph nodes. So if you could be more precise, the presvascular compartment contains those anatomic fractures, thymus, fats, lymph nodes, and brachiocephalic veins. Among the middle mediastinum, the boundaries are between, here is the middle mediastinum, the anterior margin of the pericardium, the posterior border of the pericardium, and the pleura is formed laterally. The superior border, as I told you before, as a superior mediastinum, the line extended between the sternal angle and the T4 vertebral body, and the inferior border is the superior surface of the diaphragm all along. So the dorsal to the anterior mediastinum extends from the lower edge of the sternum along with the diaphragm, and then cephalid along the posterior heart border and the posterior wall of the trachea. So those part of mediastinum contains the heart, pericardium, aortic arc, and its major branches, innermediate veins, superior vena cava, as I told you before, and of course phrenic nerve and upper vagus nerve. As I said to you before, here are the anatomic of the medial mediastinum compartments. It may also known as the visceral compartment as well. So the heart, the veins, the thoracic duct, lymph nodes, esophagus, and the trachea and the carina are the visceral compartment of the mediastinum. So we come up with the posterior mediastinum. The boundaries of the posterior mediastinum is the pericardium, bifurcation of the trachea, and the posterior lines is the T4 to T12 vertebral bodies down to the diaphragm. This space occupies the space between the back of the heart, as I told you before. It extends from the diaphragm, cephalid, to the first rib. And it contains esophagus, descendant aorta, azygos, hemazygos vein, and the rest of it. Here is the posterior mediastinum structures. It majorly contains the thoracic spine and the paravertebral soft tissues. As again, a more precise, here is the prevascular compartment, here is the visceral compartment, and this is the paravertebral compartment as a neuromo-schwannoma. Those are our clinical presentations of the mediastinal tumors, which can be an asymptomatic mass as well, which could be incidentally discovered as most commonly.
Dr. Çağatay, can I interrupt you because your slides aren't proceeding?
Oh.
There's something wrong with the slides. Is there anybody to help? Yeah, okay.
Okay, just a second, please.
Yeah, we can't see all those slides. Can you briefly repeat it, please?
Of course we can. Just a second. Is it fine now? Could you see them right now?
Right. It is good.
No.
So just let me check it. Just move one slide further.
What?
No, it's not working.
Okay then. Okay, just a second.
Share screen.
Okay, right now it works.
Okay, then I'm going to proceed just right now because I can able to make it in a full screen. I think there's something goes wrong, so I can go with this as well. Is it does it any problem with it? No.
Seems okay right now.
Okay, so let's come this way.
No.
So posterior mediastinum, paravertebral compartment. Yes. And the clinical presentation here. So actually, all those types of tumors come up with an asymptomatic mass. However, we mostly discover those masses incidentally, and 50% of all those mediastinal masses are asymptomatic, and 80% of those such masses are hopefully benign lesions. More than half are malign if with symptoms present. Effects of comparison and invasion of adjacent tissues is another clinical presentation type. Chest pain, cough because of the intrinsic compression of the trachea and bronch, hemoptysis, stridor, pleural effusion, and which comes up with the irritation of the pleural space, dysphagia, and the rest of the clinical presentations are as shown. The most pronoun form of the clinical presentation is the superior vena cava syndrome, because as a result from the increased venous pressure in the upper thorax, head, and the neck, it's characterized by dilatation of the collateral veins in the upper part of the head and thorax, and edema, pleuria in the face and neck also. And those symptoms may have a huge headache and consciousness and visceral disruption. And it's another it could be another presentation. It's a pneumomediastinum. Air in the mediastinum is a commonly complicated of mechanical ventilation, is also commonly encountered in some conditions. Pain is the most common symptom, results from scratching the mediastinal tissues. It could be also a dysphagia, dyspnea, and supratenous crepitations as well. So here's the second part of the presentation, and mainly the most important part, the mediastinal lymph node anatomy. Actually, we have to know the exact locations of the lymph nodes, where it is, because all our lung cancer management will depend on it. So if the patient has a right upper lobe tumor, which has shown as a star here, if those lymph nodes are just located this way, is number 10, it could be easily operated, and it should be operated. But on the other hand, if the same patient had another lymph node metastasis on the other side of the trachea, it's definitely an inoperable patient. So we have to know those tiny rounds where it has been located if we want to make a very precise lung cancer management. So if the patient's tumor located in the left lower lobe and the lymph node metastases are here, it's definitely another operable patient. But as if the lymph node metastases are on the other side, so it's deemed inoperable. So the location of the lymph nodes and anatomic boundaries are hugely important in terms of lung cancer management. So here's, as Professor Feraja showed us, are the lymph node mats presented in 2009. So those purple ones are the supraclavicular lymph nodes, so known as lymph node number 1. So those are low cervical, supraclavicular, and sternal nodes from the lower margin of the cricoid to the clavicle, and the upper border of the manubrium. The midline of the trachea serves as the border between the number 1R and number 1L. So we hardly ever discover those lymph nodes as number 1. We generally known as number upper paratracheal lymph nodes, lower paratracheal lymph nodes, and subcarinal lymph nodes. So superior mediastinal lymph nodes known as 2 to 4. So those are the upper paratracheal lymph nodes, number 2R and 2L. 2R lymph nodes means that the nodes are located extend to the left lateral border of the trachea, as it might be shown as R, and from the upper border of the manubrium to the intersection of caudal margin of innominate, so which we should say the left brachiocephalic vein with the trachea. The upper border of the right, the 2L lymph nodes are the upper border of the manubrium to the superior border of the aortic arc. And 2L nodes are located on the left of the left lateral border of the trachea, as which might be anticipated. So I will show on my later slides the 3 lymph nodes. Those are the prevascular lymph nodes, and 3A means prevascular, 3P means prevertebral. So those are the lymph nodes are not adjacent to the trachea like other nodes in those stations. Those are the nodes are adjacent to the vessels or the esophagus. Number 4 lymph nodes, which we mostly encountered with, are the lymph nodes intersection of the caudal margin of the innominate left brachiocephalic vein, which has been known as, like here, to the trachea, to the lower border of the azygos vein. If we pass the azygos vein, those lymph nodes are named as number 10. Number 10 means the healer lymph nodes. So those lymph nodes are not the ones that we call them N2 lymph nodes. Those are all the lymph nodes called as N1 lymph nodes as we down goes from the 10 to the number 11, 14 goes on. So as we show the number 4L lymph nodes. 4L lymph nodes are the lower paratracheal lymph nodes, and from the upper margin of the aortic arc to the upper rim of the left main pulmonary artery. So we come up with the aortic lymph nodes. Aortic lymph nodes known as number 5 and 6. Number 5 lymph nodes are known as subaortic lymph nodes. Here you can see. So those nodes are located in the aortopulmonary window, lateral to the ligamentum arteriosum. These nodes are not located between the aorta and the pulmonary trunk, but lateral to these vessels. Paraortic lymph nodes, which is we numerize them number 6. These are ascending aorta or phrenic nodes lying anterior and lateral to the ascending aorta and the aortic arteries. Those number 4L and number 5 lymph nodes and also number 6 is very important in terms of nervous laryngeus recurrence paralysis. If the patient had an recurrent paralysis, so we presume that there might be tumor on this side of the lung. It either be a tumor itself or it could be metastasis to those lymph nodes. The inferior mediastinal lymph nodes, known as number 7 to number 9. Number 7 means that it's a subcarinal lymph nodes. So number 8 lymph nodes is paraesophageal lymph nodes below the carina. And number 9 lymph nodes is lying within the pulmonary ligaments. Hilar, lobar, and subsegmental nodes are known as number 10 to 14. Number 10 lymph nodes are hilar lymph nodes, and the rest of is down into the lung. As I depicted you to before, it's more precise lymph nodes. Number 1s, as I told you before, as a subclavicular zones of the nodes. And if I'm able to show you a CT scan of it, this is number 3A. It is not adjacent to the trachea, as I told you before. It's much more adjacent to the vessels. If the lymph node is down here, it could be named as number 3P. Yes, it's much more definite. It's number 3P lymph nodes adjacent to the vertebral bodies, and it's number 3A lymph nodes adjacent to the vessels, not to the tracheal border. Here's another example of it. Yes. in the schema, my slides show those lymph nodes as a number 4, and this is the CT scan of the same ones. So number 4R, which is the lower paratracheal lymph nodes, are lying here, and number 6 lymph nodes are lying there. It's an aortic arc node. It's anterior of the aortic arc between the phrenic and the vagus nerve. Down to the, if we are talking about the, all those number 5 and 6 now lymph nodes should be medially to the ligamentum arteriosum. It's very important for us to take out those lymph nodes. It could be come with some complication. So if you take out those number 4 or number 5 lymph nodes during the operation, either in the during the mediastinoscopy or extended mediastinoscopy or during the operation, we should be avoid to damage to the phrenic, to the recurrent nerve to the patient. So those lymph nodes are medially to the, as you shown here, those number 6 lymph nodes are medially to the ligamentum arteriosum. If we go beyond these ligamentum arteriosum, we should call those lymph nodes are number 10 lymph nodes as well. So there are a lot of lymph nodes here. So those are number 5 lymph nodes. This is 3A, and this tiny lymph nodes known as number 4L. And there's only a millimeter between those number 4R and number 4L lymph nodes. So it's a very crucial point of lung cancer staging. If we should really very precisely biopsy those nodes, because all the staging processes depends on this procedure, either if the patient is an operable lung cancer or it's an inoperable lung cancer patient. So those are the number 7 lymph nodes lying down to the subcarinal area. And those are the number 10s, the hilar lymph nodules. And those are the paraesophageal lymph nodes, which is lying just adjacent to the esophagus, down to the ligamentum, pulmonary ligament. And those are the number 9 lymph nodes. Pulmonary ligament nodes are lying within the pulmonary ligament, including those in the posterior wall and the lower part of the inferior pulmonary vein. We generally take out all those lymph nodes during the lung cancer operations. So its name is mediastinal lymph node dissection. We generally dissect all those lymph nodes, and we did not left behind any lymph nodes intact. If we want to perform a decent lung cancer operation, we have to take out all those lymph nodes out to get a better result in terms of survival, in terms of better staging. And my last slides are, if you're able to perform mediastinoscopy, not EBUS, as a thoracic surgeon, we generally take out and biopsies those types of lymph nodes: the upper paratracheal, the lower paratracheal, and subcarinal regional lymph nodes. We can able to take this mediastinoscope down to the lung, and we can open the pleura, and we can take out those number 10 lymph nodes as well. But it doesn't mean quite anything, because if the number 1 lymph node is still involved with the tumor, it's still operable ones. But if those types of lymph nodes has been involved with the tumor or metastasis, then our surgical procedure could able to change. We can either send to the patient to the definite chemotherapy without an operation, or definite chemoradiotherapy without an operation, or we can either send to the patient to induction chemotherapy, and then we can able to perform an operation on those patients. So we can able to take out number 5 and 6 lymph nodes by performing an extended mediastinoscopy. It's a quite hard operation, quite dangerous one. But if we can put this mediastinoscope on the aortic arch down to the pulmonary artery, we can easily sample those number 5 and 6 lymph nodes as well. We can able to perform an anterior mediastinotomy those types of patients to take off those lymph nodes as well. So I can able to finish my talk. Before curative treatment, we have to know the exact locations of the nodes. You can follow our website to get more information for cure your disease as well. Thank you very much. Can able to wait.
Thank you, Dr. Çağatay, for your excellent speech. Are there any questions or comments on this topic? I think it's well understood too. Very good speech. Thank you, Professor Çağatay. And right now we proceed to break. And after the break, my other colleague, Professor Dr. Handan Zeren, will talk about the rapid on-site evaluation. So this is very important in diagnosing EBUS. Therefore, I think she will give perfect speech about the tips and some reviews from the pathologist view. So we're waiting after the break.
Good day and welcome. My name is Katerina Tikhanova. I'm from Ukraine. Me and my colleagues from different countries gathered here to help you and to give you the best medical care. Let me explain how the things are working here. First of all, we are receiving an email from you. It contains your request, all information about your disease, medical reports, MRI, X-rays, screens, etc. After that, we are sharing all that information with a certain doctor and taking his medical second opinion, which is MSO for short. The doctor prepares your own treatment plan accordingly. After that, we are taking the cost of that treatment plan from our accounting department and sending the offer to you. If you are accepting the program, from that moment you can start to prepare your plane ticket. We are also helping you with the hotel accommodation, transfers, and arranging your own translator. At your arrival day, we are meeting you with our VIP cars in the airport and bringing to the hospital. We are honored to know you as a Live Hospital family. We are ready to help you 24 hours a day, 7 days in a week. Live Hospital International Patient Service wish you a healthy days.
Здравствуйте, меня зовут Нигина Исмаилова. Я являюсь ответственным лицом по медицинским запросам в клинике ЛИВ для стран СНГ. Наша команда состоит из 40 человек. Мы занимаемся предоставлением второго медицинского мнения. Для этого пациент отправляет нам свои медицинские заключения, лабораторные исследования, если есть радиологические снимки. Специалисты клиники ЛИВ рассматривают и составляют план лечения и диагностики. Алгоритм требующихся обследований, а также их предварительная стоимость отправляется вам на почту. После того, как вы подтверждаете план диагностики и отправляете нам дату вашего приезда, мы организовываем вашу предварительную программу обследования. В случае надобности помогаем вам с резервацией отеля. Также предоставляем вам трансфер с аэропорта в аэропорт. Передаем всю вашу медицинскую информацию, отправленную вами, русскоговорящему переводчику, который будет вас сопровождать в период вашего пребывания в клинике. В день вашего приезда наши коллеги по логистике встречают вас в аэропорту и привозят в клинику ЛИВ. Сейчас вместе с вами посмотрим продолжение. Мы, как клиника ЛИВ, гордимся тем, что нам предоставилась честь узнать вас. Отныне мы являемся частью вашей семьи и готовы вам помочь круглосуточно касательно вопросов вашего здоровья. Международный отдел клиники ЛИВ желает вам благополучных дней.
Live Hospital, which promises to be the future of healthcare with its experienced patient care and guest-oriented approach, opened in Wadi Stan.
Welcome, Dr. Handan. Hi. Just open the microphone, please. You are on mute. Just go to the down of the screen. Yes, okay, it's right now.
Is it open right now?
Yes, and you have to share screen.
Okay, I did, but let's see.
Mhm. You go to down of the screen and the green button. Can you see it?
Can you see my screen right now? You know you
No,
can.
just we are seeing your beautiful face.
Thank you. Okay. Smooth.
Maybe our friends, IT friends, can you call Professor Zeren in order to help her?
Well, I'm trying to share my screen, but I cannot do it. Some other things are coming instead of the screen.
Maybe.
Alo. Problem ben
Sorry for the technical problem. So
Alo. Evet, şimdi tekrar girdim.
Dear guests, sorry for this pause because of the technical problems. We are trying to solve the problem. So if you don't mind, we need 10 minutes more in order to arrange the slide projection. A few minutes later, I hope we will listen the talk of Dr. Zera. Dear colleagues, we are very sorry about this problem, but the technical problem is not over and we cannot fix it. So I think we have to stop this today's program. So we apologize from each of you, and the pathology part of the course is cancelled. Thank you very much for your cooperation. Thank you very much for your appearance. Thank you.